It's time for DocTalk Radio, brought to you by Gilbert Hospital and Florence and Anthem Hospitals. I'm Dr. Ann Borik, board certified in internal medicine, and I'm here to keep you up to date on the latest information pertaining to your health and well-being. Welcome to DocTalk Radio. Joe, we have a special guest in the studio today. We have Dr. Robert Fintelman. And, I got to tell you, oftentimes I tell my patients that, I treat my patients like I treat my family. And actually, Dr. Fintelman was a surgeon, the eye surgeon that took care of my mom. And by the way, she's doing fantastic. So
very good to hear.
Thank you. Thank you for being here. It's going to be a great show, and I just can't wait to get in because there's so many things to talk about.
Pleasure to be here.
Tell us a little bit about your background.
So I was born and raised in Germany and then came to the U.S. about 7 years ago to complete my training. I did a residency in Philadelphia at Wills Eye Institute.
Oh, really? Okay.
And then moved to San Francisco for a year to do a fellowship. So I'm fellowship trained in cornea external disease and vision correction. And then afterwards I came here to Phoenix, Arizona, where I'm working now at Barn Delaney Perkins Eye Center.
That's a huge practice.
It's a very large practice. Yeah, we have about 10 surgeons and another 20 doctors in our practice, and we have locations all over the state.
Wow.
In Phoenix, Tucson, Flagstaff. We sometimes also go to Scholar or different locations.
Different locations around the state. So your specialty is in cornea, cataract, and corrective eye surgery. Or
correct.
Like
vision correction, that's usually what I summarize it to. That includes LASIK and ICLs and all the other things you try to, options I should say, that you can go through to get out of glasses.
Let's talk about that first, because it's interesting. LASIK and the different ways that we correct vision now. Tell us a little bit about, what's available, what's out there.
So it kind of depends what you're looking for and how old you are, honestly.
Okay.
If you're a young person, there are several options available, and I always try to approach it the way I approach anything, like by the location that we correct your vision at. So, as you know, contact lenses, for example, sit on the very surface of the eye, on the cornea.
Okay.
And cornea refractive surgery, meaning LASIK, for example, or PRK, any kind of surface ablation, also reshapes the cornea. I like to compare it into permanent contact lenses, if you will, so that instead of putting contact lenses on your eye, the front part of the eye works like a contact lens.
Got it.
And that is usually done with laser, so the laser vision correction is usually what that implies.
Is there an age limit that's recommended? Would you because the eye changes as we get older, right?
So there's a few things that we like to look at. Number one is the eye stable, so it would make very little sense to do a surgery on somebody whose refraction, meaning whose glasses are changing every year, because this is like a permanent refraction. If it changes again, then you kind of just went through a surgery without getting the benefit you would want.
Right.
If you come into older age, let's put it this way, you at some point will need to wear reading glasses. And when we sometimes see patients, they have good distance vision, but they can't see things up close.
Right.
And then there's at this point, some options available for them, correcting one eye for distance, one eye for near, for example.
Oh, wow.
That tries to keep them out of glasses. But if they say, I just want near vision, then they would lose their distance vision. When you get into the age range, which we're going to talk about later, where you develop cataracts, again, it wouldn't make much sense to change just the cornea because there's something else that's interfering with your vision. My poor comparison is if you sit in a car and the windshield's dirty and you have nice clear glasses on, you really still won't be able to see well because the windshield's still dirty.
Right.
So that's kind of one of the examples I like to use. And this drawing should kind of help a little bit, just kind of tell you where things are. So the very front part of the eye, the cornea, is one part where the refractive surgery takes place, and then the lens, which sits behind the iris, is the part where the cataract happens. So if the front part is clear and the back part interferes with your vision, just doing refractive surgery in the front doesn't make sense. So
for LASIK surgery, for example, if somebody's 25 years old, do you recommend it at that age? Because the eye continues to change until we reach a certain age, isn't that right? Or
usually we say it's usually pretty stable by like 18, 20.
Okay,
that's when
that's important.
That's kind of the main, just like anything else. Once you've reached your final height, so to speak,
I see.
Things kind of stop growing as well as the eye. And the length of the eye has something to do with the refraction you will need. So if the eye gets larger or bigger, you tend to get a little bit more nearsighted over time.
Got it.
There are some patients that do still continue to change later on, And those, I would say, probably not a good idea to have refractive surgery because, again, it doesn't interfere or doesn't stop the process of your eye changing, just like you said.
Got it. Let's talk about cataracts, because I think that's a huge topic. You know,
It
there's
is.
so many people with cataracts, and as the baby boomer, population is getting older and so forth. First of all, what is a cataract?
Cataract, I like to compare it to a cloudy lens. It's literally what happens inside the eye, as you mentioned again, if you might hold up my little picture there.
Yeah,
The lens
other
itself
way.
becomes cloudy. Thank you. The lens itself becomes cloudy, and then you don't see as well. It's almost like getting dirty glasses. So even though everything else is clear in the front part of the eye, you're looking through fog, through haze.
What causes that?
Literally just aging. We know that some of the proteins inside the lens change over time. They become denser, they become more, change their composition and their orientation, and thus they block light more. And it's literally like when I look in, it's always like the fog. That's why a lot of patients describe it to me like a film over their eyes, which again, it's not over, it's literally inside the eye.
It's not painful, though.
No,
No.
not at
Okay.
all. It's a painless loss of vision, and usually happens over years. That's why some patients come in and say, "Oh, I have cataracts. I didn't know that." And
Right.
I always joke and said, "I have the beginning of cataracts because if you live long enough, chances are you're going to develop a cataract."
Right. Now, there are different types of cataracts. Is that right?
So if you kind of look at the lens, and my pure comparisons again in M&M, everybody's eaten an M&M
Okay,
in their
uh-huh.
life, so you have a sugar coating around it and then chocolate inside, and the chocolate is the part that becomes cloudy with time. And the orientation of the cloudiness would kind of relate to the different kinds of cataract. So you can have a cloudiness just very close to the sugar coating. You can have the whole lens that becomes denser and denser, nuclear sclerotic cataract, we usually call that. That's the most common one, and that's the one that changes most slowly. So again, over time, it just becomes more darker. It's almost like wearing built-in sunglasses, if you will.
Interesting. Now, is trauma, does trauma set you up, kind of set the stage for developing cataracts?
Absolutely. People who have trauma can develop a cataract at a much earlier age. So I usually say, people in their 50s, 60s start developing cataracts, and by the time you're 80 or 90, 50, 60, 70% will probably have a cataract that's visually significant, meaning interferes with your vision. But when you have trauma, any eye injuries, sometimes also surgery, that can hasten the development of cataracts to much, much earlier.
So boxers, for example, or football players, or head trauma, is there known evidence? I don't know. This is an interesting.
That is a very good question. So for as far as head trauma itself, no, because
No,
the eye
okay.
itself is very well protected.
Okay.
But if you get a direct injury to the eye,
To the
meaning
eye.
get hit in the eye,
Got it.
or not that I want that anybody to happen, but get a perforating injury to the eyes,
Exactly.
like being stabbed in the eye or anything like that, that can definitely hasten development of cataracts. Very aggressive eye injury, or again head injury, like you said, can weaken the suspension apparatus of the lens. So the lens doesn't just float in the eye, it's suspended by very small little tiny fibers to keep it in place, and
Right.
they can also kind of get affected by, just like anything else, by trauma.
Okay, that's interesting. How do we protect against cataracts? We all want to protect. In the sun, we live
absolutely.
in Arizona, and there's sun exposure. Is there a direct correlation there?
People haven't really found a direct correlation, but some think that sunlight, especially UV light, tends to hasten the development of cataracts. Especially in Arizona, my recommendation is always to wear sunglasses, not only
I
for
need to hear that.
not only for cataracts, but also for protection of the surface of the eye. You can develop the same as in any other skin. You can develop cancers. You can develop. We spoke about that before, melanoma. So I think eye protection is always important.
Right. Are there certain colors of eyes that are more, apt to developing cataracts versus, dark eye versus somebody that has blue or hazel eyes? Does that have anything to do with it?
The eye color, with that sense, not so much. More if you have darker iris, meaning a darker eye color, usually you're more protected from,
Okay.
let's say, melanoma. Yeah, that tends to happen more in Caucasians or blue-eyed people.
Okay.
Lighter skinned.
Interesting. Joe, do we have any questions there?
We do. We have one here. 51 years old with astigmatism, wear bifocal glasses. Would it be wise to choose to fix eyes for close vision and wear glasses for distance vision?
Great question. Also, because it's one of the most difficult questions for me to answer, I always ask patients, what is your goal? Like, in the end, I'm trying to help you achieve what you want.
Right.
So if you're saying, I read all the time, I work on the computer all the time, my life, for example, within a room, my life is really reading, then that may be a good choice. But on the other hand, reading glasses are really, really cheap. Like, if you buy a pair of readers, you can get them in the dollar store for $3, $4. So
Right.
for me, oftentimes it makes more sense to correct somebody for distance, and then they just need a pair of reading glasses for up close. Again, the other thing that we mentioned already, one eye distance, one eye close would be another option.
How is that received? Because, I mean, to me, it would seem to be kind of confusing, or it would be irritating.
And then I can already tell you from the get-go, it won't work for you.
Yeah, there's no way.
No, patients who, that's my kind of triaging questions, like, does that sound like a good idea to you? They say no. I was like, okay, that's the end of that discussion.
If I just have a smudge on my glass, it drives me crazy, so it would be very difficult.
There are some patients who love it, and for them it's a great option, but it's a hit or miss. It's either it works great or it doesn't work at all.
Right. What can people expect if they're going to be preparing for cataracts? Is there a thing that you do prior to prepare, and then after the surgery? Just kind of give us a little.
Absolutely. So cataract surgery actually has changed quite significantly over the last 10, 15 years.
Okay.
It used to be and I have patients still in value that. My grandma had cataract surgery. She was in the hospital for a week.
Yeah,
she was
that's
in
exactly
sandbags. She took off the patch like 3 days later, and then you just like see, oh my God, yeah, I see something.
Right.
These days, it's not really a big change as far as preparing for it. So you don't even have to stop most of the time your blood thinners. It used to be that you need to stop Coumadin, aspirin, all those things. Not really anymore. They're still the same as with any surgery. No eating for 8 hours before the surgery. You start eye drops the day before surgery, and you usually are on drops for about 4 weeks after. But as far as restrictions after surgery, all you really need to do, and this is a joke again, but take it easy, basically. I wouldn't recommend starting to move furniture in the house or starting to do a big project right afterwards.
Right.
Or you decided that, I haven't worked out in a long time, now I'm just going to start weightlifting. But that is only for 1 week. After 1 week, pretty much all restrictions are gone. And the vision, at least usually, tends to improve even within the first few days already, and then the final outcome is after about a month.
Right.
Surgery itself takes anywhere from like 10 to 30 minutes.
It's
usually
amazing.
painless, and it's
Amazing.
in and out the same day. The other thing, again, that I hear, I'm sure you do as well, is like, do I have to go to the hospital? Do I have to be admitted? Do I have to stay overnight? All no. It's the same day outpatient surgery, which is great. Again,
Right.
It's like patients come in, they leave, and that was it.
I guess it's really vitally important to use the eye drops after surgery.
Yes, and the main risks that we always talk about is, for me at least, risk to the eye, risk to vision. And even though it's a very low risk, it's definitely there. Just
Right.
like with any surgery, nothing is without risks. And the eye drops help with decreasing inflammation, help prevent infection.
Right.
That is one of the also subjects and areas that's at the moment there's a lot of research, because obviously nobody really wants to participate in research. It's like, hey, let's find out what decreases the risk of infection. You won't
Exactly.
take drops and you will take
Right.
drops. But as far as retrospective review, meaning looking at patients afterwards, like in the past, it seems to be a protective factor to be on an antibiotic eye drop.
Okay. It's interesting because I've had a couple patients who, within 24 hours of their surgery, cataract surgery, end up in the hospital with pneumonia or whatever the case may be. I actually had a patient that fell and fractured her ankle, the next day. And one of the things as a hospitalist that, because I'm not real familiar with, the high specialty of ophthalmology, to protect the eye, so I was really on the phone trying to get a hold of the surgeon and knowing what to do. So that's
a great
important.
question. Absolutely, and thank you for bringing that up. So I as you know, they have an eye protection, eye shield, and we usually say wear that while you sleep for 1 week. And that's not really to prevent any lens from falling out. The lens is very, very safe.
Right.
It's more to prevent any inadvertent eye rubbing. Because the wounds, there's no sutures anymore. It's not blade surgery, but without the sutures are self-sealing, so they're constructed like a valve,
Okay.
and the pressure inside the eye keeps it closed. But if you imagine now pressing from the outside, that could theoretically open that. So that's why for the first week we say, wear a shield when you sleep. If I tell you not to rub your eyes during the day, you won't. But at night, you forget.
Exactly.
Scratch you, and then
Right.
just to prevent that
Just
from
to
happening.
prevent that
exactly.
trauma. Yeah,
But again,
that's-
it's nothing. It's also not the end of the world if you don't do it. It's like again another preventative mechanism to protect against bad
to
outcomes.
protect the eye.
Exactly.
Absolutely. For those of you listening, I just want to give you the number. This is Dr. Robert Fintelman. He is really is a prominent eye surgeon here in Arizona. Works for Barnett, Dulaney, and Parkins, one of the bigger ophthalmology groups here, cornea, cataract, and vision correction specialists. 480-745-1033. And I'm actually straining to see here. I have an astigmatism myself, so, let's talk about progressive lenses. It's amazing. As soon as you turn 40, the eye changes. And I got to tell you, personally, people that I know, my friends, it's almost like that clock is just, right on.
And we usually say 42. That's when it hits.
Is that what you say, 42?
Well,
Okay.
It's again, it's not really that, but around that time, and it's mostly that the eye, it doesn't change; it just loses ability to focus. So the lens that I showed you before, it usually has the ability to bring things into focus up close.
Right.
And so when you turn 40, it gets quote unquote stuck at a certain distance, the distance that without glasses you would be at. So if you're nearsighted, you take the glasses off. Obviously, you're still able to see, but when you put your glasses on and you see well at distance, you then lose the ability to bring things up close. Astigmatism is something that can be both in the lens as well. We've talked about the cornea before, and it's just a different shape of the cornea. To explain that, I usually try to explain it this way. If you look at a regular lens, let's say a magnifying glass, and you hold it against the sun, you get one nice spot, one focal point.
Right.
When you have astigmatism and you would have a lens that corrects astigmatism, usually that light is not focused in a point, but more in a line. So it's, if you look at your prescription, it's usually two numbers. One we call spherical, which is again just like round. All directions have the same curvature. If you look at a basketball, for example, in every direction you go is the same curvature. The second number is usually the astigmatism, and that is more like, it's not really like, but more like the side of a football, where one curvature is flatter and one is steeper.
Got it. That's interesting. I know there's calls and we're getting some things in, but I want to get to nutrition for the eye. Because again, as we get older, we want to protect the eye. And on this show, there's so much research that we try to talk about in terms of nutrition. Tell us a little bit about, nutrition for the eye. What is the best thing to do?
So nutrition for the eye, I always say, if you eat healthy, you will protect the eye as well.
Okay.
So for me, important things are, for example, fish, again, green leafy vegetables. And why? So there's one big study called the age-related eye disease study, AREDS. Some people have heard of that in relationship to both cataracts prevention. They were trying to look at which supplements actually protect you from cataracts, and age-related macular degeneration, so a condition that affects the back of the eye, the retina. And they found that certain supplements, including zinc, for example, beta-carotene, vitamin C, and vitamin E, do show a promise in protecting people from progressing if they have intermediate age-related macular degeneration. As you can see, there's a lot of kind of variables to take into care. It's not a general statement, everything is good. No, there's certain people that would benefit from it.
Got it.
If you are not in that category, I still think it's wise to eat healthy, just because it won't hurt the eyes and it will definitely help the rest of your body.
Absolutely.
The other thing, since we live in Arizona, that I always want to bring up as well is omega-3 fatty acids has been now shown that it helps the retina. It also helps my specialty, again, the cornea, the front part of the eye, because it tends to help prevent or treat dry eyes, which I'm sure a lot of people suffer from here as well.
And we'll talk about that.
Absolutely.
So that's the omega-3 fats. That's interesting. In terms of, you can't take too much of it. I mean, you've got to be careful.
Thank you. Yes. I think with anything, there's always a
right, and I want to make sure that our listeners know that, because even though we're talking about the importance of supplements, sometimes the fat soluble type vitamins you can overdose on.
Yes.
A, D, E, K. You've got to be very careful.
And that's why I again say, if you take it in through normal nutrients, again, vegetables and fish,
salmon,
you can't overdose through that, because it's the body decides for itself how much it wants to absorb, as opposed to taking a really high concentration with a supplement. So I totally agree, and that's why, in general, I think it's wise to try and get that in with nutrition as opposed to supplements, except if you're in one of those high-risk groups. And interesting enough, speaking about cataracts, they did not find that it protected from cataracts. Age-related macular degeneration, yes. Cataracts, no.
Interesting. Okay, that's great. Joe, we have a question.
We had Bob from Scottsdale call in, and he said you personally did his surgery, and he can see perfect now. He thought he was going to be blind. He said, Dr. Fintelman is the best. Thanks.
Oh, thank you.
I got to tell you, today at the hospital, one of the case managers, we were talking about me having to come over and doing a show at an off hour. This is not our, but you actually did the surgery of one of our case managers at the hospital, and she just raved and raved about you. And I said, well, he did my mom as well. So we've been talking about you. And so really thank you for being here. That's great. Joe, any other comments or questions there?
No, we're good right this minute.
Okay. Melanoma, I know you had mentioned that. A friend of mine just recently had an eye exam and said that there's a freckle that they noted. Is that something to be concerned about? I mean, what is the incidence of melanoma or cancer?
Fortunately, the incidence of melanoma inside the eye, usually called choroidal uveal melanoma, is very low. in general, with any freckles, just like as you know, skin dermatologists will tell you the same thing. I think it's worth watching.
Okay.
And there's certain characteristics that are more not dangerous, but they kind of give you a higher risk for it turning into melanoma. The overall risk of that is really low.
Okay.
But I usually say if you have that, probably watch it
Any
once a year.
symptoms that that?
That is the problem with that. Usually, just again with a freckle, it would be something that we see looking in.
Right.
Yes, that changes, but if it comes to your attention by symptoms, it's usually already pretty advanced.
Got it.
So I think again, prevention makes more sense than trying to catch up with it later on.
And so I think the message is really make sure that you get your eyes examined, a dilated, good, comprehensive, thorough eye exam.
Absolutely,
Very, very
and especially
important.
again, as with anything else, as you get older, I think it becomes more important to do that. There are certain eye diseases that we call silent thieves of sight, glaucoma being one of them, that are difficult for you to know if you have. However, if you've been checked, then less likelihood, and oftentimes whoever checks you can then tell you, oh, it's safe to go a few years even without being checked. Because some people think they have to be seen every single year unless terrible things will happen.
Right.
It depends on you,
And
and
that's not the
oftentimes
case.
if you see somebody, they say, oh, you know what, everything is fine, we can see you in a few years.
Very good, very good. Dry eyes, being in the desert, huge.
Absolutely.
There's Sika syndrome, and then is it the same as dry eyes, or is there a different? Because I know there's an autoimmune, connection with Sjogren's syndrome and dry eyes, dry mouth. We test it, with different antibody blood tests, and then there's just dry eye. Can you kind of bring some clarity around that and the
Trying
the
to,
difference?
but even for us, it's a very wide range of these conditions, I would say, diseases as well as conditions, because if you see an eye specialist, if you tell them you've had some eye irritation, some feeling of dryness, you get labeled with the term dry eyes.
Right.
And oftentimes it's not that your eyes are too dry in the sense of you don't produce enough tears. Like you said, the Sika syndromes, Sjogren's disease can cause that, where your tears, quote unquote, dry up.
Right.
It's more that your eyes feel irritated because relatively they don't have enough tears. So let's say, like you said, you live in the desert. If you take a hairdryer and point it directly at your eye will be too dry.
Got it.
And so it's more situational. There's a lot of things that also contribute to that eye irritation. And this is purely semantics, so I apologize in advance, but I usually like to call it eye irritation and then trying to figure out what exactly is the problem.
Right.
One of the things that a lot of people do, and we live in a society like that, is if you are on the computer a lot, if you work on a phone a lot, if you read a lot, you tend to blink much less because you're trying to focus on something and not miss anything.
Okay.
If you blink less, your tears are distributed much less, and so relatively you have not enough tears. But if you were to take a break, close the eyes, relax, that's one option. Lubricating drops help a lot with that as well, but it may be you only need them at the computer, you only need them when reading.
Interesting.
In
Okay.
addition, there are certain inflammatory, and stop me please, but that's
no, this
obviously
is good. This is what we want to
There's
hear.
certain inflammation of the eyelids themselves as well, and these can also contribute to irritation of the eye. If you imagine you sleep at night and inflamed areas on your eye all the time, you wake up with red eyes, you wake up with irritated eyes, and treating that can also provide a lot of
What
relief.
causes that?
Blepharitis is one of the other things that happens more, I should say, with age. People think that some of the bacteria that live on the skin change with time, and your body reacts to them more. It's not, as you know, we all have tons of millions of bacteria on our skin, which is nothing bad.
Right.
But there's certain that tend to be more irritating than others. And also with time, your eye loses some of its buffer to tolerate things.
Got
so
it.
as you get older, you lose some of the ability to just say, you know what, I feel okay, but the eye gets more and more irritated with time.
Interesting, and that's why oftentimes you'll recommend antibiotics or steroids, where you just kind of put it over the eyelid.
Exactly. One of my favorite treatments as well, because it
And
tends
it's
to help.
effective.
Yes, without causing a lot of the side effects of steroids, which inside the eye, if used chronically, can cause, as you know, higher pressure,
Sure.
glaucoma, or again, cataract. So that's why I try to use it as little as possible, but if it's necessary, it's necessary. And I'm sure you've seen patients who are just miserable, but because they can't function, they can't see, they can't do anything.
Yep.
And everybody who sees them is like, oh, you're fine, there's nothing wrong with your eye.
And that's exactly, just personally with my mom. I mean, that's exactly until she came to see you, and I got to tell you, it's miraculous. I mean, it's amazing how good she's doing.
Yes, and people always are surprised, like, oh, the eye can hurt that much. It's like, yeah, it can.
It really can. And when your eyes hurt, your whole body hurts, and you
don't want to do anything.
And you don't want to do anything. There's a question, I think, Joe.
Linda from Delaware. She works outside, And when she takes off her sunglasses, it takes her 3 to 5 minutes to readjust to her prescription glasses. 49 years old and healthy. Anything I can do?
Good question. First question to Linda would be, when was the last time she had her eyeglasses checked? The reason for that is, as we said, as you get older, the eye loses the ability to bring things into focus. And if you are, for example, nearsighted, as a young myope, nearsighted person, you love stronger glasses because it brings things more into focus. Not necessarily sharper, but more definition, higher definition, I would say, so more contrast. And as you get older, you lose that ability. So then if you, let's say, have two different prescriptions, then the eyes need to adjust to the new one, and trying to get used to that new one will take a little time. So one recommendation, I guess, would be to try and keep both prescriptions the same, or again, just give the eye time because it takes longer. Speaking of one of the things you brought already up, falling and irritation.
Yep.
Interesting enough, also with cataract surgery, people always say, like, is it really necessary or does it help?
Right.
And other than the obvious improvement in your vision, people have actually found that doing cataract surgery in elderly, where the risk of falls is much higher, decreases the risk by 30%, which I
huge.
think is huge.
And you know what that translates into are less hip fractures.
Absolutely.
You know, we have people that come in, end up with blood clots
Yeah.
after, and they end up dying. I mean,
Yes, it's not, falling for elderly people is not a fun thing at all. And that's why people always ask, like, should I really have this? I'm so old. I'm like, it actually will improve your safety at home. So,
absolutely.
because as you also know, older people need more light. If you imagine having built-in sunglasses, you need even more light to overcome that.
Right. Let me ask you, exposure to smoke, for smokers, secondhand smoke.
Thank you for bringing that up. So that's also one of the things that people think hastens the development of cataracts. So stopping smoking, diabetics actually can get cataracts faster. Better blood sugar control is important.
Okay.
Smoking also a lot of irritation to the eyes itself. Just being in secondhand smoke causes a lot of irritation because, again, if you imagine the surface of the eye being bathed in a tear film,
Right.
if you imagine smoke over that, that kind of can get trapped in the tear film,
Ooh.
and then you have a permanent irritation on the eye. Some people are very sensitive to that. Some, as you know, other people are not at all. Otherwise, they wouldn't be smoking or working in a place where there's smoke, secondhand smoke.
Right, right.
Okay.
Genetic
Where are you
problems
calling
with
from?
the eyes. Is there a genetic predisposition to cataracts, for example?
You can, absolutely. There are some congenital cataracts, so babies who are just born with cataracts right away,
Okay.
and these are treated pretty aggressively. The reason is if the brain doesn't learn to use the eyes well, meaning doesn't know that it can see out of one eye,
Right.
it literally, and I'm putting this in quotes, turns the eye off. So if you see young children who, for example, have crossed eyes or have one eye that doesn't see well, the other eye sees much better. I'm sure you've seen people walk around with a patch over the
Sure,
eye.
sure.
And until the age of 10, it basically forces the brain to use the eye that is not as strong and forces it to use it. After the age of 10, it's not really that effective. So it's another fear that I have commonly. Patients who say, oh, I walk around with a patch, will I damage that eye? And it comes from knowing that as a child it can, not
Right.
as an adult.
There's something that I often have talked about just in giving lectures and so forth called tricking the eye. And I want to ask you, is it accurate? Is it true? For example, if I were to look at something on the wall, that picture or that cross or that, image, and then close my eyes and visualize it, from what I understand, the brain doesn't know the difference. Is that true? Is that accurate?
Yes, because where does seeing really happen? It doesn't happen in the eye. The eye, for
Right.
example,
That's
just works like a camera. The real vision happens in your brain. So it takes those images, those impulses, that information, and makes it into a picture. So absolutely, for all you know, the brain wouldn't know a difference between what it sees through the eyes to what it sees while imagining it.
In visualization.
Hence also the very, very vivid, if somebody has hallucinations and they're visual hallucinations, they're very, very disturbed because for them it's real. And
It's
for
real.
all intents and purposes, they cannot tell the difference at all because it looks exactly the same.
That's interesting. Is that pretty much how visualization, some of these high athletes, golfers, they visualize their swing, or, racquetball players or tennis players, and their skill set actually is enhanced by visualization type exercises?
I'm not sure if it's necessarily due to visualization, meaning seeing things, but I truly think is preparing and going in your mind through the different steps of even
Of
movement.
movement, of
Exactly. They
movement,
know exactly,
right.
okay,
Right.
this is what it should
Yes.
feel like almost. So everything
Exactly.
is reproduced in the brain and thus practiced also that way. So
Yes,
you don't really
yes,
need to
the
do it as long as you
proprioceptive, yeah.
exactly as long as you know kind of what it
Interesting.
should feel like.
Very, very interesting. Joe, there's a question.
Yes, Scott from Phoenix. I lost an eye in the military, 44 years old. Is there anything out there to get a new working eye? I wear an eye patch and hate it.
It's a very
Wow.
two answers to that question. Number one, unfortunately, we're still far away from what we see in Star Trek, where people just get a new eye or can see with an implant. There's work being done to try and implant a small camera into the eye,
Wow.
that then into a blind eye that then sends impulses to the brain, almost like a cochlear implant for people who can't hear. That obviously has to be done in an early age, but we're not at any stage where we would say, oh, people should just go out and get that. So that's one aspect about function. So unfortunately not for now. And also transplants doesn't work with the eye because it would be like a nerve transplant, and hooking exactly the right nerves up to each other is at the moment impossible as far as I know.
Wow.
There is another aspect saying, like he was saying, he was wearing a patch, and that's probably just from appearance. And there are options to make it look like the other eye, absolutely. I'm sure you've seen some of your patients that you don't realize have a glass eye until you get very close and you're like, oh, that's a fake eye. I didn't know that. And myself as well. I see patients in the practice all the time. I swing all the stuff, and I'm just like, oh, that's not a real eye. I'm glad I caught that just now. So there are definitely options, yes, that can make it look more natural. Unfortunately, as far as vision, at this point, no.
That's interesting.
But
Wow.
speaking of, we actually see quite a few veterans as well, because Marjolaine Perkins actually also takes care of the VA in Phoenix. So we see a lot of veterans and take care of a lot of veterans, which is a very gratifying experience, actually.
Interesting. Cornea. Let's talk about the cornea. I know that you're a corneal specialist. Just for our listeners out there, just give us a little information about what you do as a corneal specialist.
So cornea, if you think about it, is the very first clear layer of the eye. So if you compare it to a watch, it's the very front, the glass of the eye. You can see through. That's why it appears colored to everyone, because the iris, the color part, sits right behind it. So everybody's like, oh, it's the color part of the eye. It's like, well, it vaults over the color part of the eye. And just like my comparison with the different windows, if one of those windows doesn't work well, you are not seeing as well. And anything that affects the cornea affects your vision usually. So it can be corneal ulcers, it can be keratoconus, so a change in the shape, corneal ulcer being an infection of the front part of the eye, an abrasion. I'm sure a lot of people out there know how much it hurts the front part of if you get scratched.
Right.
You can have swelling of the eye, Fuchs, endothelial dystrophy. So if you think of the cornea as three layers, you have the top layer, which is the skin, which hurts so much when you get scratched. The next layer, which is the structure of the eye, which gives it its form, affected by keratoconus.
Right.
And then the innermost layer, a lining consisting of pumps or cells that keep the cornea clear of fluid. If those don't work, you get more swelling and you're almost looking through fog. People with Fuchs tend to have that sooner. Everybody's born with a certain number, and you lose them over time. Surgeries can affect that. Fuchs can affect that. And what I then do is, again, various levels of treatment with drops and or surgery, including a corneal transplant.
Wow, that's interesting. I know there's another caller there, but I just want to ask you, we have a Facebook page, and, DocTalk Radio, and we have a lot of people that are, sending questions, and we had a question not long ago about twitching, eye twitching. Is that something to be concerned with? How do you treat it? What are your thoughts and what are your recommendations to your patients that, have this persistent nagging eye twitch?
Very good question, because there's also different kinds. I'm sure almost everybody has experienced it at some point when it feels like you have a little twitch right there. And the three most common reasons are always stress, caffeine, and not enough sleep. And usually if I tell the patients, they laugh and say, yeah, I have all three.
Exactly.
If it's something that happens intermittent and goes away, usually nothing to worry about. It's almost myoclonus, so small jerking movements of one of the muscles.
Right.
And it's usually just one muscle that's affected. If it gets worse or affects other parts, then it might be worth actually asking a neurologist to take a look and make sure everything else is okay.
How long do you give it? Can you go up to 2, 3, 4, 5 months, or what are your experiences with that?
It's a good question. It depends on the circumstances of a patient, and I can give myself an example. When I was studying for exams, I had it everywhere. And once the exams were gone, it went away. But it took months because I was in a high-stress situation where I needed to take a lot of exams.
Okay.
So it more depends on the circumstances and on other things. It's more if the neurologic exam, for example, is otherwise totally non-focal, no other deficits,
Right.
then I would probably not be as concerned. If there's other deficits, then I'm glad that this was one of the first presenting symptoms,
Sure.
and then we can go from there.
Got it. And that makes sense. Yep.
Sarah from Trenton, New Jersey, used a friend's makeup and ended up with herpes of the eye. Can I ever get rid of this, and am I eventually going to go blind?
Excellent questions. And as a cornea specialist, that's the other thing I deal with. Herpetic eye disease is a very huge topic, and most of the time it can affect the front part of the eye, including all parts of the eye. Most of the time, and that's why I kind of want to put a caution on that, it's not transmitted via makeup. Oftentimes it's coincidental, like you use somebody's makeup and then you get a flare-up. I compare herpetic eye disease to either cold sores or shingles. So if you look at a cross-section of the population, probably 80 to 90% have, as you know, antibodies against it, so are infected at some point. And once the virus is in your body, it stays.
Right.
It's there to stay. And most of the time, once it affects the eye, it's one of the worst things that I see because I already know, and people know the comparison with the cold sores. Like, oh, so you're telling me it's going to come back because they know cold sores come back. And most of the time it can come back, yes. If I have somebody who has chronic recurrences, there's one way that I can treat it to control it. In the long run, it can cause scarring if it's not controlled. So it depends what level it affects. If it's under control, it doesn't have to cause blindness at all. It doesn't have to cause a lot of problems. But again, it's important. And that is one of those things I would definitely observe and kind of watch and make sure that everybody knows the warning signs and symptoms when it flares up again.
Right.
And ideally, you would control flare-ups because every time the virus comes, it leaves, and I'm putting this in quotes again, footprints.
Now, do you recommend that you put your patients on long-term, acyclovir antiviral medications by mouth, or is it just drop form, or how do you?
So there's several antivirals for the eye. Usually we have the advantage that if you have a problem with the eye, we can treat it directly right at the
With
source
drops,
of the problem
right?
with the drops. The one exemption, at least for me, is antiviral drops. Why antiviral drops? Now, one can be irritating to that. They work, but they're pretty aggressive, and they don't get very far deep into the eye. As we just said, herpetic eye disease is a systemic problem. So my preference, at least most oftentimes, is to treat it systemically. I would not put somebody on long-term prophylactic dose unless they had recurrences or unless it's already close to affecting their vision.
Right.
If it is somebody who is at risk or who has proven to me that they have recurrences or already needed, God forbid, but I've done that as well, who needed a corneal transplant for herpetic eye disease, and again, it's always a conversation with the patients, like, are the risks of taking the medication, do they outweigh the benefits of taking them? And it's always a back and forth. And I listen very closely to my patients because it's honestly, I help them manage their disease, but it's them doing what needs to be done. I can give them the tools, but I can't manage it for them.
So you started in saying that it is not transmitted by using somebody else's makeup.
No,
is that right?
Exactly. It's like most people get it at some point during their life. It's oftentimes adolescence, and you can, how can you get it? You can touch something, you can touch your mouth, you can get it. And again, once it's in your body, it's everywhere in your body. So, and it's also not a sexually transmitted disease, because when I put patients on acyclovir, one of the first things that in the pharmacy they'll ask, like, oh, do you have that? It's like, no, it has nothing to do with that at all.
And that's important to know. That's good. Joe, another question.
Nancy from Tampa, Florida. I sleep with my eyes open. It's a medical problem. I have constant eye problems such as dry eyes, blurry vision, hurt eyes, running eyes, and more. What can I do?
So sleeping with the eyes open, even though it sounds like a
Is
funny
that common?
thing, it's more common than you think.
Wow.
And I'm sure you remember me checking your mom's mom. She actually closes her eyes all the way. And a lot of people don't even know. And you think that it's something little because, come to think of it, your eyes are most of the time open throughout the day. However, when you sleep, you don't blink. So you have this one area of your eye that's constantly just dry. And if you imagine holding your eyes open for an hour, you know how much that will affect your vision and it will hurt. So most people, it depends on why the eye stays open at night, but that's why some people use ointment at night. Ointment doesn't evaporate, so it just serves as a protective barrier to keep moisture in. And one of the things that is pretty simple, even though it sounds interesting, is using a piece of tape. My favorite one is a breathe right strip, the thing that people use for snoring.
Yes.
The pediatric size, we just put one on the top of your lid, pull down a little bit, lift up your cheek, put the other one on the bottom. The eye stays closed at night. You can still see that the eye is closed, nothing is open, and you have great protection. You don't need to use any ointments, and they're not that expensive. Up to, some people actually need surgery that keeps their eye not completely closed, but at least more closed, so they have better protection to the surface of the eye. And like you already mentioned, that's a perfect example. She has irritation from the eyes being open, which feels dry, which is correct because that area is dry.
Sure.
But she also has running eyes because the eyes try to compensate and lubricate it more. So labeling that just as dry eyes would, in my mind at least, miss the point a little bit.
Mm-hmm. What do you do about people that have constantly running eyes? I mean, you know, is that a problem? Is that something that you see often, or?
I do, but it's not a problem in the sense of does it damage the eye? No, but it's extremely, again, annoying because
it's a nuisance.
It's a big nuisance because patients get asked like, why are you crying? And they say, I'm not crying. That's me.
Right.
Oftentimes it is either from a closure. There's two little ducts that lead out of the eye in the lids, and when they get plugged up, it's almost like the sink is overflowing. Tears are constantly produced. They can't drain into the nose, so then they drain the other way, meaning down their cheeks, for example. Opening then is usually a surgery performed by a specialist, an oculoplastics specialist.
Right.
Sometimes it can also just be as little as extra irritation, just like the lady that called before, that leads to an increased production of tears that then can't drain the normal way because it just overwhelms the normal eradication mechanism, if you will. So that then leads to a decrease in the irritation, then also will decrease the tearing.
That's interesting. I know we got a lot of calls. This is a really interesting.
And you know,
segment.
Most of them have not been local. This one is, I've never gotten a call from Williams, Arizona before. Becky from Williams, Arizona. Got a lie burn in left eye 5 years ago on Thanksgiving. Now my eye is scarred. Can you fix this? I want to see again.
And just, first of all, I'm terribly sorry. That's a terrible, one of the worst injuries you can have to the eye, because lye is really toxic, as everyone knows. And the problem with the eye is it doesn't just stop at the surface. It can damage the surface. Actually, the way the eye can heal itself is completely damaged by lye, and once you get that scarring, it doesn't go away. It used to be that the only treatment for that was and I'm going to go a little bit in theory as well, but a limbo stem cell transplant. So the stem cells that repopulate the surface of the eye, the surface, just like the skin, continuously undergoes exchange, and if that is damaged, then you get just scarring that never goes away. Even if you remove the scarring, it scars right back over. Even a corneal transplant in itself wouldn't help, because those cells are not transplanted with a regular corneal transplant. Some people transplant the stem cells, but that then we were talking about usually, actually we haven't mentioned that, but usually a corneal transplant, you don't need to be on systemic immunosuppressions.
Right.
You just need to be on drops. With a limbus stem cell transplant, it's a completely different ballpark. You are on really heavy duty, because there's a lot of blood vessels, so you need to be on immunosuppressant systemically.
Right.
However, and that's why I want to address that too, there is a device out there called the Boston keratoprosthesis, which is a little piece of plastic that is integrated into a corneal transplant, and so even if the transplant fails, scars over, that piece of plastic is always clear. So yes, the answer is there is a possibility to treat that. It is a large commitment though, because once you have that in your eye, it's not like anything else. A lens inside the eye, it's secured, no big deal.
Right.
Usually you don't get infection, but this is now exposed to the surface, so you always need to be checked.
Oh, wow.
You need to be on antibiotic drops all the time, and you definitely need to regularly see an ophthalmologist or somebody who can exchange a contact lens, which decreases one of the main risks, which is that things around it melts in, so that the implant doesn't stay in the eye. So the short answer is yes, it can be treated. The long answer is but there's a lot. Yes, exactly. There's a commitment. But it's still possible. Like she said, I want to be able to see out of it again.
Absolutely.
And that is possible. And I've actually recently done Stevens Johnson, but a patient similar, bad scarring, hadn't seen for 17 years out of both eyes, and he's actually able to see again somewhat. Not as good as he was before, but at least better functional.
That's amazing. That's a great question. Thank you for
that is a very great question. And I'm sorry again for that injury, because that is a terrible injury to have.
Wow.
Phil from Mesa, Arizona. I'm diabetic, under control with pills, 45 years old. When I eat a big meal, my eyes water like crazy. Any idea why?
Only with a big meal.
Only with a big meal, I suppose.
So there are some reasons why that can happen. It might be less from diabetes, but from other. If other causes, if you have an injury to the nerve that supplies the lacrimal gland, and you have a nerve that usually supplies your salival gland, if that gets, so to speak, crossed wires, and now suddenly the salival gland nerve
That's interesting.
intervenes
Wow.
the lacrimal gland, then you can get a lot of tearing. But it wouldn't usually be both eyes, which would be just one eye, and usually you would have had to have some kind of nerve damage. The only other thing that I can imagine is depends on what kind of big meal he eats. You know, if there's a lot of heat involved, lots of spicy food, again, that's honestly not
Habaneros or
exactly,
salsa
I'm
or
not quite
something
sure.
like that.
Yeah.
All of those can be irritating, and that can definitely cause more tearing.
Dairy products, is there any relationship with increase? Because I know that sometimes we talk about increased mucus production and that kind of stuff, but with tearing, there's no direct correlation with dairy.
Not
as far as we
not
know.
as far as the eyes, at
As
least.
far as the
Like
eyes,
in,
okay.
in otherwise, yes. One of the things that I also wanted to bring up, because we spoke, kind of mentioned at least the implants for the eyes after cataract surgery, that, you know, especially these days, it used to be that you had one choice. It was like you're getting that implant and that's it.
Right.
Now, we mentioned that before as well, as like cataract surgery and vision correction are kind of getting closer and closer together, just because we now have options. You mentioned astigmatism. There are certain implants into the eye that can correct astigmatism, so you don't need, for example, for you wouldn't only need reading glasses as opposed to glasses for both distance and near. There are certain implants that correct distance and near vision, multifocal, so
Oh, wow.
they give you, they don't work like progressive lenses. They split actually the light between distance and near, so you have images of both, and the brain chooses which image it's going to use. There are certain lenses that try to replicate what the lens usually does, meaning accommodate, so focus near and far. Then don't work as well, I should say, yet, because there's always the hope that somebody will come up with something that works better.
Right.
And then, as you probably also heard now, we even do parts of the procedure with laser. It used to be, so initially when cataract surgery started out, it was a manual approach. So we did a large incision, we removed the lens completely in one piece and then put a new lens in.
Wow.
Now the incisions are much, much smaller, maybe 1/10 of an inch. We use phaco energy, meaning sound energy, to break up the lens in very small pieces.
Okay.
Remove it through that small incision, put a new lens that's actually folded into that. It unfolds inside the eye. Some of those incisions can now be done with laser. Part of breaking up the lens can now be done with laser. Tends to give it a more predictable outcome because, as you also know, something done by hand, that's why a lot of people value something done by hand. It's unique. It's always something a little bit different.
Right.
Versus something done by a machine is always exactly the same.
Precise.
Which in a cataract surgery, if you're trying to improve your vision, is beneficial because you can better you can better calculate or kind of predict what's going to happen once you have this.
Got it.
Less variability.
That's interesting. Wow.
It's called LensX. That's one of the brand names. Not that I want it, but that's at the moment the one that's mainly approved in the U.S.
Wow.
Lindsay from Payson. Sometimes I see great, other times blurry. Eye exams always show 20/20 vision. Is it my eyes or something else, Dr. Borik or Dr. Fintelman? Can you help?
So blurry vision from time to time depends on how long and under what circumstances. Like we said before, could it be that, for example, while reading, the vision suddenly gets blurry? If it happens, please.
And if somebody has a question, because they didn't give us enough info, can they email you?
Yeah.
Or
Absolutely. I mean, you already mentioned the
Yep.
Facebook page, so yeah,
Yep.
that would be one way to
That
kind
would
of get
be-
the.
yep.
Sorry to
question
interrupt,
me.
Doctor.
No, please. That's good. It's a good question because otherwise, they won't know. It's just lost in the ether somewhere.
Right.
If you have intermittent blurry vision, like vision is crystal clear, like she mentioned, then it suddenly gets blurry.
Right.
Can be, for example, from a problem with the surface of the eye. So, for comparison again, but if you drive during the rain and everything is nice and clear, and suddenly you get an oil slick on your windshield, you won't see from one moment to the next. Then the oil slick clears, and now I see again.
Right.
With the eye, if the tear film is affected and the tear film does not work as you would like it to be, meaning crystal clear, then you can have intermittent blurry vision that can last anywhere from brief period of time to long periods of time, because then again the surface is so irritated that it can't clean itself up very easily.
Okay. What can you do? I mean, are there recommendations?
Again, it kind of
for-
depends. If the tear film is not perfect, we talked already about nutrition, like omega-3 fatty acids, flaxseed oil also tend to improve things. Warm compresses tend to make things better. And I want to emphasize this: gently cleaning the eyelids, not scrubbing, but gently cleaning the eyelids can help. If I look at the eye, sometimes the tear film can almost look like soap. Honestly, I see little bubbles. And if you've ever had soap in your eye, you know that doesn't feel that
Right.
great, and also can affect your vision because it breaks up the tear film. Going back to that, thinking about the tear film, you can think of it as 3 layers. One layer is kind of a mucus, which attaches the tear film to the surface. Next one is an aqueous layer, that serves as lubrication, obviously, and the top layer is lipid. What that does, it prevents the evaporation of the water under it. So if you have a breakup in the lipid, your film water evaporates very quickly, and you get that short
It's amazing
blurriness
how
of your
the
vision.
eye is created.
Oh, absolutely.
It really is. It's an amazing machine. Wow.
Yes, and everything needs to function just right for you to see well.
Right,
so.
right. You know, what about people, you know, in the summertime swimming, opening their eyes underwater, the irritation of chlorine, you know, what do you recommend to your patients to avoid that completely, or?
I don't think it's anything particularly bad, but again, it depends on what kind of person you are. Some people are very sensitive to it, so I guess one of it is common sense. If it irritates you a lot, don't do it.
Don't do it.
But I don't think it causes any permanent damage to the eye. I wouldn't recommend necessarily doing that with contact lenses. And contact lenses, if you think of them, they're little transparent discs that sit on the eye, and they almost work like sponges. So anything that gets in the eye will stick in the contact lens for a long time. So let's say you go swimming, you get some nice chlorine in those contact lenses, it will stick on there for days. So those contact lenses are probably toast.
Right.
And also pool water, not as clean as you would like it to be, and that never is. I mean, no offense to anybody who has a pool, but it's not as clean as,
As you
no pool
think.
water in the eye, let's put it that way.
Exactly, exactly.
Seth from Santa Barbara got a pizza pepper in his eye 5 weeks ago. Has been having bad headaches and redness ever since, every day. Could there still be a pepper stuck in my eye?
Yes, first of all, just real quick, because sometimes any kind of foreign body can get stuck under the eyelid, and if you don't flip that and look at it, it's going to be there continuously.
He said he rinsed it with something he bought at the pharmacy.
Even then, because it's literally, if you think of the eyelids, they rest right on the surface of the eye, and they kind of go over it all the time. So if it's stuck in between, even rinsing it, you won't be able to lift that off. One of the other things, speaking of peppers, a lot of people handle, especially in this part of the country, I love that as well, but hot peppers, habaneros, jalapenos, and if you handle them and then touch the eye, it's a bad idea because, number one, it hurts like crazy. Pepper spray comes to mind.
Yep.
And also it can actually change your pupil size. Not permanently, but for a little while. So if people touch their eye and then they suddenly get a large pupil, that's from that as well.
That's interesting.
So always wear gloves while doing that.
That's
it
good to
sticks
know.
on the eye, in the hands, on the skin for quite some time, and it doesn't hurt the skin. But let me tell you, once you touch your
It's
eye, it
painful.
hurts a lot.
Anisocoria, which is
Capsaicin,
with a difference in eye pupil size. And whenever I see a patient, I always assess that. And when I see that one eye is bigger, the pupil are not equal, I always ask about it. And it's interesting that you say that now that'll be one of my questions.
Yeah.
Have they been handling peppers and that kind of thing, right?
They would remember.
They would remember.
It's
Okay.
not something they would easily forget.
Right, but sometimes it it
No,
doesn't
absolutely.
occur to them.
No, because
if
it's like,
they
oh
come
no,
in
it's like,
for-
oh, did you get something in your eye? It's like, oh yeah, come to think of it.
Right,
yes.
exactly. That's interesting. We're almost out of time. Do you
Really?
believe how
Wow. No, I
quick
didn't.
this hour has gone?
Yes.
But we're getting a lot of calls, and so this is great. I want to make sure that we address as many as we can. Dr. Fintelman, anything else that comes to mind that you want to talk about before we see if there's any other questions out there?
I guess one of the other things that you brought up beforehand that I guess I didn't answer completely is you asked about other options for vision correction. And one of the other options, if let's say you're not a candidate for LASIK because again your cornea is too thin, you have other changes.
Right.
There's two other options. One is called an implantable contact lens or implantable Collamer lens. That's a little lens that gets folded up into the eye and then it actually rests on top of your own lens. So it doesn't affect the cornea very much. You don't get any laser surgery that way. And if it's reversible. If you don't like it, it causes problems, you can take it out again. The other one would be similar to cataract surgery, using the same techniques as cataract surgery, using the same implants again, multifocals, toric lenses, or one distance lenses implanting that inside the eye. And since cataract doesn't come back, that would be one thing to have that earlier. I have some patients who, I think it's always part joke, part real. It's like, if I'd known this surgery I probably would have had it like years ago.
Wow.
And that's something I want to bring up. The next one is just, again, talking about predictability. I get sometimes questions also from outside doctors or patients who've had surgery elsewhere, that the surgery wasn't a success because they didn't get the prescription that they wanted, meaning none. And the way we calculate the lenses is still based on numbers and averages of population. So we look at a population, we create formulas based on that population. But if you ever looked at any kind of distribution, that's always a distribution curve. So
Right.
always a little bit, most patients are where we want them to
In
be,
the
but
middle.
there's always some outliers.
Right.
There's some technology which tries to address even that. One thing that's fairly new is called Aura. It's a automatic refraction in the operating room. Like once the patient is out, the lens is removed, and then it just double checks and makes sure that we put the right lens in while it's there. And that's less based on formulas and calculations, but literally on a direct measurement right there.
Wow, so it's more objective.
Correct. There's more. I am always amazed that you think, oh, this is already where we are. Like, technology is not going to advance. Like, nope, it's still advancing.
It's amazing how new things keep coming.
Cheryl Ann from Atlanta, Georgia. I smoke a lot, and I'm a very nervous person. Every time I smoke, my eyes hurt, and I see blurry almost instantly. Can't seem to quit. Anything I can do to help?
I'm sounding mean now, but trying really to quit smoking would be best. Again, no, sorry, this is a bad joke, but again, clearly the smoke itself can be a very big irritant, and if that gets into the eyes, it causes instant blurriness of vision, and it doesn't stop until you stop smoking. I guess one of the options is, if it really is impossible, is smoking outside, very, very well ventilated area, that kind of thing, or I'm not trying to say that, but trying to, chewing a nicotine gum, that kind of thing. So anything that can do without smoking.
Right. Absolutely.
And I'm sorry for giving a
You
half answer there, but that's truly what I feel.
If that's the cause of it, that's what has to be taken away in order to, to end up with
and
a
it's
good
very,
result.
and I know it's hard to stop smoking.
Sure.
Don't get me wrong. It's like, that's why I'm very happy that in Arizona we have the smoking cessation, the hotlines, and things like that, which I think is an amazing offer.
Yep, it really is. Well, Joe, I can't believe this hour is just about over.
Definitely been action-packed.
Anything?
Wow.
Any other questions? Anything
Yes.
else before we?
Not right this minute.
Okay. Do you have any questions, Joe? Anything that you can think of?
I didn't have time to think.
Okay.
So
All right.
I'm good right now, but
Okay.
I definitely learned everything I heard was
This
awesome.
has been a great hour. Thank you so much for
my
coming
pleasure.
and sharing with us. And I know that some of your colleagues are going to be joining us.
Again, we talked about diabetic retinopathy,
Right.
diabetes, how it affects the eye, macular degeneration.
Right.
And as I said, I'm
A
also happy.
huge
Yes,
topic.
clearly, we specialize, and then people say, "Oh, you subspecialize in the eye in parts
Right.
of the eye." I say, yes,
Yep.
because there's a lot out there. So.
Right. There really, really is. Again, thank you so much for
My pleasure.
coming.
Thanks for having me.
This concludes DocTalk Radio with Dr. Ann Borik. Till next time, I wish you health, wellness, and many blessings.
DocTalk Radio is brought to you by Gilbert Hospital and Florence and Anthem Hospitals. Topics discussed are for informational and not intended to substitute advice from your personal physician.